For the masters endurance athlete over the age of 50, pushing their physical limits is a daily routine. They possess a level of cardiovascular fitness that far exceeds the general population. Yet, this elite performance is often abruptly halted by the sudden onset of atrial fibrillation, or Afib. It is a highly disruptive arrhythmia that immediately compromises cardiac output and forces the athlete to stop. The standard clinical response to restore their performance is a catheter ablation procedure. A specialist physically enters the heart to neutralize the rogue electrical signals causing the misfire. The clinical data reveals a counterintuitive outcome. Following a successful ablation, highly fit athletes who return to high-volume training experience significantly higher rates of arrhythmia recurrence than completely sedentary, non-athletic patients. Elite cardiovascular fitness does not grant immunity from heart disease. In this specific population, the athletic lifestyle itself drives the failure of the medical intervention. The standard surgical correction is pulmonary vein isolation, or PVI. Targeted energy creates a ring of scar tissue around the pulmonary veins. By isolating these veins, the ablation traps the chaotic signals, effectively restoring normal sinus rhythm and resolving the symptoms of Afib. Because the symptoms vanish, both the athlete and sometimes their primary care provider fall into a psychological trap. They view the ablation as a definitive reset button for the heart. Operating under this assumption, the athlete clears themselves to immediately return to peak performance training, often subjecting their heart to more than 10 hours of intense cardiovascular strain every week. While PVI successfully silences the localized electrical trigger, returning to chronic high-intensity endurance training is a clinical error. It guarantees the progression of the hidden, underlying disease process. To understand why the ablation fails, we have to look at the structural changes in the athlete's heart. The left side shows the healthy, muscular thickening of the lower ventricles, but the right side reveals the pathological stretching that occurs in the upper chambers, a condition known as Bi-atrial Dilation. The primary etiological stimulus driving this damage is years of chronic volume loading. Pumping massive amounts of blood during endurance sports, exceeding 10 hours a week, mechanically stretches the fragile atrial tissue over time. The cellular consequence of this continuous mechanical stretch is myocardial fibrosis. This is the formation of microscopic, rigid scar tissue embedded directly within the otherwise healthy atrial walls. This fibrosis physically disrupts the heart's normal electrical pathways. When a smooth electrical signal hits this web of scar tissue, it fractures, creating a chaotic and heterogeneous tissue environment. These swirling, fractured currents form what electrophysiologists call macro-reentry electrical circuits. These self-sustaining loops of electricity are the true, underlying engine that drives atrial fibrillation. Intense exercise also creates an extreme autonomic trigger. Endurance athletes swing between resting bradycardia, an unusually slow heart rate, and massive sympathetic adrenaline surges during workouts. This swing shortens the atrial refractory period, the brief resting phase between beats, effectively igniting these dormant circuits. Chronic endurance training structurally damages the heart's upper chambers. Ablation removes the initial spark, but heavy training continues to build the highly combustible fibrotic substrate. This chart plots arrhythmia-free survival over a 3-year period, comparing athletes who continue to train post-ablation against non-endurance controls. The 3-year survival data shows a steep drop-off. While the sedentary control group stabilizes at 48%, the endurance athlete group plummets to 34%. The ablation fails the athlete because of the ongoing mechanical strain. The pulmonary veins remain successfully isolated, but the relentless endurance training continues to stretch and scar the remaining atrial wall. This ongoing damage has a specific clinical manifestation. The recurrent arrhythmia in athletes often bypasses the treated pulmonary veins entirely, presenting instead as atypical flutter originating in the newly damaged fibrotic tissue. Returning to maximum performance training after an ablation actively drives the disease to progress into more complex, widespread arrhythmias. Patients often make a dangerous assumption following treatment. They believe that because their heart rhythm feels stable, their risk of a stroke has been eliminated. Stroke risk is determined by the CHA2-DS2 FASC scoring system. This is a strict, objective medical standard that calculates stroke probability, heavily weighted by age and comorbidities like hypertension, regardless of the patient's current heart rhythm. Randomized clinical trials have never proven that catheter ablation reduces stroke risk. The structural thromboembolic threat, the risk of a blood clot forming in the damaged atria, remains active. Ignoring this reality carries a severe statistical penalty. As this data shows, prematurely discontinuing oral anticoagulation medication or blood thinners results in a massive increase in stroke events, with a hazard ratio of 2.48. The clinical mandate is absolute. If a patient's score dictates the use of blood thinners, the athlete must take them indefinitely. This strictly contraindicates any return to high trauma or bodily contact sports, no matter how stable their rhythm feels. The Masters athlete over 50 also faces a second compounding threat: generalized atherosclerotic cardiovascular disease, or ASCVD. This plaque buildup in the arteries occurs right alongside their electrophysiological damage. Managing this requires differentiating between standard LDL cholesterol and its truly dangerous variant, small dense LDL, or SDLDL. Because of their physical size, these highly atherogenic particles easily pierce the arterial walls to initiate plaque formation. There has been a strict shift in modern lipid management. The medical focus is no longer on the total quantity of your good HDL cholesterol, but rather on its mechanical functionality. This metric is called cholesterol efflux capacity. It measures the specific ability of an HDL particle to act like a cellular garbage truck, physically extracting lipid molecules out of dangerous arterial plaques. When lifestyle interventions aren't enough, physicians use targeted pharmaceutical interventions, like high-dose EPA, an omega-3 fatty acid, to reduce residual lipid risk. However, high-dose EPA carries a known risk of actively increasing Afib incidence. Treating the aging athlete is a delicate balancing act. Optimizing their lipid profile to prevent a heart attack can inadvertently trigger the exact arrhythmias the athlete just paid to have ablated. To manage both the structural damage and the rhythm disorder, the Masters athlete must shift their objective. They have to move away from maximum endurance performance and focus strictly on cardiovascular preservation. This J-shaped curve plots exercise dose against cardiovascular risk. Low activity is dangerous. Moderate is protective. But extreme volume is physically toxic to the atria. To stay protective, cap total volume below 10 hours a week. The target is 210 minutes of moderate to vigorous activity. Specifically, the protocol requires Aerobic Interval Training, or AIT, which alternates short bursts of intense effort with recovery periods. Clinical data shows that AIT actively reduces the mean time an athlete spends in Afib from 8.1% down to 4.8%. This specific protocol allows the athlete to maintain their elite VO2 max and cardiopulmonary fitness without continually tearing apart their atrial substrate. Adopting this structured, moderated exercise intervention directly translates to an 18% reduction in the relative risk of Afib recurrence. A successful catheter ablation is merely a localized patch over a systemic exercise-induced structural failure. It does not cure the underlying condition. Long-term cardiac stability requires the athlete to step away from the extreme endurance environment and adopt a measured, controlled approach to their physical exertion. For the Masters athlete post-ablation, reducing and restructuring endurance training is not a reluctant lifestyle concession. It is a mandatory, life-saving medical therapy.